Hi, good evening. I'm Dr. Philip McMillan, and today I'm bringing you some really concerning, disturbing news based on a recent publication out of Japan. As usual, the Japanese seem to be the only ones who are really asking hard questions. They're doing the work that needs to be done in terms of doing autopsies. For anybody who has been following me, or if you're just meeting me, I have been hammering home these points about autoimmunity around the spike protein in COVID and other sources. And I've been saying that we need autopsies to understand what in the world is going on. For all the people who have lost loved ones suddenly with no obvious explanation, I think by the end of this presentation, you'll have a better idea as to potentially, and I say potentially because this is only scratching the surface, potentially what is going on. And I'll be highlighting this specific case with regards to cardiac multiple microscars and autopsy study. And as I said, this is out of Japan. I wanted you to see the date. It's March 2025. This is hot off the press. Nobody has picked this up. And the reason, truthfully, that I'm able to share with you hot off the press is because I actively search for any paper that has histology or autopsy around COVID to try and understand what is going on. If you don't look, you can't see. And sadly, I'm from the category of clinicians and researchers who, based on the science, sadly, I expect problems. And therefore, I actively look to try and understand what is happening, what could be going on. So, before I start, I'd just like to highlight to everyone in the same way that I look in terms of all aspects of COVID, I am looking hard at some of the strange things that have been happening with regards to measles. And so, if you want to understand some of the perspectives that I have here, the unseen threat about measles, and why I think this is going to intensify, you need to join me at this upcoming webinar. I realize a lot of people think, well, it's just measles. But when you see the interaction between COVID and this virus, it is absolutely fascinating to see how the combination of both of them are likely to give us a lot of trouble. So let's get back to this presentation. You may have to go to my Substack to see the full thing. And so remember to look in the description below. That's also talking about my ongoing concerns about spike protein. This is just reinforcing that point and highlighting that we really need to insist on thorough autopsies going forward. So the first stage is that I'm going to prepare you with the basics of the science, because if I move on to telling you about the paper, you may not understand some of the points. I'm going to try and give you a little bit of insight into the background as to what happens with the heart. So here we have a normal heart, what we call a normal heart here. This is showing you the whole heart. And on the left-hand side, right-hand side here, this is a cross-section of the heart. And so the heart has four chambers. The blue tends to represent veins, venous blood, coming into the right side of the heart. It is then pumped out through the pulmonary veins to the lungs. Then it comes back into the heart, and then it goes in the right side and it's pumped out through the aorta. And when you look at the cross section here, you can see these four chambers. And what's important to note is that the most significant part in terms of pumping blood is the left ventricle. And you can see it's thicker here. This is a septum between the left and the right ventricle. And critically as well, electricity in the heart tends to come from the atria. And so the electricity that powers the heart and makes it contract usually starts here. And that's an important starting point for you to understand why this is likely to be relevant. Now, when you think of scarring in the heart, you oftentimes have heard about things like a heart attack or a myocardial infarction. And in this image here, this is showing you here, again, the heart. You can see the blood vessels here. If one of the blood vessels is blocked, and so blood can't get through, you can then end up with a large scar in a part of the heart here, for example, could also be here, anywhere there's a blood vessel. And this becomes a scar tissue, myocardial infarction. But these are big scars. And sometimes when they're doing autopsies, they will be able to observe these scars and therefore make a diagnosis. And that's the principle and of external autopsies, where you take a look at the heart. If you see a big scar that's fresh, it would suggest that the person has died of a myocardial infarction. The other thing that you would have heard recently is the concept of myocarditis. So, whenever you have itis on anything, it usually indicates inflammation. And in this case here, myocarditis, again, this is a heart. I just saw this area here, it's a bit redder. This represents the inflammation. And when you look, this is now, if it's blown up to histology, that means they'd take a sample of this area, put it under a microscope, and then look and see what happens. And you can see here that the muscle cells are broken up a bit. There are lots of inflammatory cells around. And then you have fibrous tissue forming as well. And this also can cause a scar, but a much smaller scar in the heart. That's from myocarditis. That's very important in terms of what we're going to be talking about next. Because what they had found in the paper, and this is the new diagnosis, and I'll show you in the paper that they had not seen before, is cardiac multiple microscars. Now, you have to understand that in order for you to get the imagery, I've made them bigger, but these are likely to be tiny. But the point is that what you're likely now to be having, instead of a big myocardial infarction, you have multiple tiny scars scattered around throughout the heart. Now, you may think, well, that's not a big deal because the heart will still beat. The problem with the scars is what happens to electricity and triggering of electrical signals in the heart. And this is the bit that is very important in trying to understand this new condition. And where you'll see it manifested most frequently is in terms of a cardiac arrest. And for those people who have been observing, they may be noticing that they are hearing more and more about cardiac arrest. But it seems that the science has reliably told you that that's just in your mind. You're not hearing more about cardiac arrest. You are just thinking you are. Anyway, let's move on. And now let's get to another piece of the puzzle that will help you to understand the paper. And that's to do with a normal ECG. And what you have here is all about the electricity in the heart. The P wave makes the atria contract. There's a delay between when this triggers the atria to contract, and then the QRS complex represents ventricular contraction. And this is because the atria pump blood into the ventricles, and then the ventricles pump the blood around the body. And then this is just the repolarization, and then it goes again. Important to note that this P wave here usually starts in the atrium, not in the ventricle. And it's one connection, so to speak, between the atria and the ventricle that then makes the ventricle contract. And that bit of information about the electricity in the heart is very, very important because there are two conditions I'm going to mention here. One of them you may have heard about, and in this one is atrial fibrillation. Here is a normal ECG, just as I showed you, P wave, QRS complex, T wave. It goes again, P wave, QRS complex, T wave. And you'll have this happening about 70 times per minute, and that's what makes your pulse go when the QRS complex contracts the ventricles. In atrial fibrillation, instead of you having nice, consistent electrical firings, it's all over the place. You can see that there is no clear baseline. There is firing of P waves all the time. And critically, these QRS complexes are now irregular. And this is an important diagnosis because it helps us to know who may be at risk of things like stroke disease. It's not going to cause somebody usually to have a sudden cardiac arrest. But the point I'm making with it is that it's all about electricity in the heart. Then you have another condition that you have to be aware of, and this one is ventricular fibrillation. And again, you have a normal ECG. Here you go, P wave, QRS, T wave, P wave, QRS, T wave. But here, suddenly, you have this complex, which looks more like the QRS complexes, and they're just firing all the time irregularly. And in this situation, the heart is not beating, and that's what can lead to a cardiac arrest. So you may think to yourself, well, what's the connection between all of this and these multiple microscars that I'm talking about? Well, the problem is that these can potentially trigger ventricular fibrillation. And if they're in the atrium, they can trigger atrial fibrillation. So these scarring bits are suddenly very, very important. And so it's critical for us to try and understand what is going on. So that's the background. And as I said, you may have to look at the Substack to see the full presentation. But that baseline should now help you to understand a little bit more about what this paper is saying. Okay? If you have just joined us, we are talking about a new condition, a new diagnosis that has not been seen before, observed by the Japanese, who, as usual, are doing proper science. They are not just letting people die without doing accurate and detailed autopsies. And because of this, they're finding stuff that we should have known already. For anyone who has been following me, they will know in April 2023, the first case or the first autopsy of a fully vaccinated person who died of COVID was done, published at least. Can you believe that? We had the vaccine roll out in early 2021, and the first single publication was done in April of 2023. I don't know what to call that, but it's not good because the implications for public health and population health are horrific. Let's get back to what this paper actually said. This is now a case series, and as I said, cardiac multiple microscars, and they have identified this point about unexplained cardiac arrest is often attributed to patients' underlying heart disease. However, it is well known that an autopsy can reveal pathologies that were not noticed before death. I sometimes wonder whether or not there is a block on autopsies because they don't want to know. Because for me, if you really want to know and you're having excess deaths and you're not sure why people are dying, the obvious thing to do is to do autopsies. This is what the Japanese are doing. And of course, they are finding out absolutely unusual patterns. Now, again, it's important to note that they haven't said what the cause is. They are just observing and they are trying to make sense of what they're finding. And here is what they said in the paper. At our clinical pathological conferences spanning about 30 years, multiple myocardial scars, microscars in the myocardium, other than in cases of myocardial infarction, a heart attack, that's why I told you that, had never been observed. Okay? They have never seen it in 30 years. Additionally, there have been no reports of these microscars in the myocardium by pathology as far as they were able to find. So this condition has never been seen by them in 30 years, and there are no papers that suggest that anybody else has ever seen it. And critically, they highlight in the paper that if you're doing a simple autopsy external, you'll never see it because you can only see it on histology, looking under the microscope. And you would never see it by something like a MRI, which can sometimes pick up myocarditis. So anyone who's telling you that they've done MRIs and they're not seeing the myocarditis and so on, without histology, sometimes you will not be able to know. So it's giving us a picture. Now, I'm going to go through the three cases that they spoke about. The first thing I want to do is prepare you for those people who are going to try and discount what this paper is saying. We have a whole bunch of people who are so concerned about protecting a narrative that they will do anything to prevent you from looking at the obvious. And one of the things they're going to tell you is that the patients that they were looking at are older. And so, therefore, their cases may not be necessarily as important because there are a lot of young people who are having things as well. So, let's just look through the cases and you will see why the Japanese were doing this important work. Patient one was 75 years old. She had bronchiectasis. This is a lung condition. They produce a lot of sputum and they're prone to infections. And on her way by ambulance to the emergency department, oh no, she was being transported because of a cardiac arrest. So they instituted resuscitation. They managed to get her heart back after 3 cycles. Then they did a 12 lead ECG and they found that she was having lots of unusual electrical activity, we call premature ventricular contraction and ventricular tachycardia. Remember the image of the ECG. But they found that her heart enzymes are normal. When they did the echocardiogram, the contraction of the heart, the ejection fraction, was normal. They did another lot of investigations and they found a clot in terms of her lower lobe of her lung. And then she went into cardiac arrest again, and then she died. And because of the appearance of the new ventricular arrhythmias and the cause of the cardiac arrest not being clear, they then obtained consent to perform an autopsy. That is excellent medicine. You see, they could have easily just said, she's 75, she's got a lung condition, she had a cardiac arrest, let's move on. She's older, don't worry. This is why I'm saying is that if you are not looking for problems, you're not going to find them. And this is exactly what's happening at the moment. And if there are any clinical people who are watching, please don't ignore when you have unexplained conditions that we need to find answers for. It's very important. And it's only if we try and get answers that we will sometimes stumble into new conditions. And this is exactly what has happened in Japan. The second patient that they spoke about in this conference was 91 years old. And she had heart failure 2 years earlier. And then she had worsening heart failure. And they couldn't figure out why her heart failure was worsening because there was no change. And then this time she presented with new onset atrial fibrillation. Now, again, I had recently gone through a case with someone who was a loved one who was so upset that their partner had died. And they had new onset atrial fibrillation, then had a stroke, then had some other complications. And they were convinced that the jabs were the cause of the death, fundamentally. And so, as I went through objectively, one of the points I made to them was that the atrial fibrillation in an older person, they just can happen and they can be at risk for stroke disease. However, as you now look at the pathology and you start to reflect on these patterns, you realize that you can't conclusively say that there was nothing going on in the heart in the first place. And this is what I mean. We need far more investigations to try and understand what is happening. And this patient here, as I said, when you look at the characteristics of these patients here, you have patient one, patient two, patient three, two females and a male, 75, 91, and 93. And they looked at the weights of the heart. This 91-year-old had heart failure, so she had a much bigger heart. All of them had multiple vaccinations. And this was the point that was coming up in the paper. They realized that there was no other clear cause or association that they could find. Only one of them, patient 3, had a history of COVID. And in terms of their left ventricular ejection fraction, this was also largely normal. And there was no clear cause of death. In patient 3, they thought that maybe lymphoma would have been the cause, but it wouldn't cause a cardiac arrest. And this is why they then went on to be doing this kind of pathology. So you have a situation here where patients are dying and they don't know why. So what they then did an autopsy, look in detail at the heart. This is just good medicine. Why has it been absent for so long? I wonder what else we're going to find. But let's go back to the paper here. So this is what they then found, is that when they then did the histology, they started to see all these little white areas, grayish areas in the heart that are scars, multiple scars all through the heart muscle. So when I showed you the picture, I kind of showed you big scars, but these are micro scars that just are scattered throughout the heart muscle. And what is going on? They had never seen this before. Luckily, they were looking for it because they then found similar patterns in multiple other patients. And this is why they've come to this conclusion. This is another example of these multiple scars. And they were trying to work out where these scars were in relation to the blood vessels. Were they because of blood vessel blockage in the heart muscle that then caused these tiny little scars that can then potentially go on to cause arrhythmias, unusual arrhythmias. Here is another image that they showed you in the paper. And you can see all these tiny scars all around in the heart muscle that are occurring. This one here, the scars here, the different staining, and this is in different parts of the heart. This is the right atrium that they're seeing, that left atrium, left ventricle, right ventricle. So in all four chambers of the heart, they are seeing these little micro scars scattered around. This is very unusual, and this is what caused them to speak about it in terms of their in terms of their conference. And what else they did is that they then started searching, could this be in other organs? So they went looking. So for other organs, including the lung and the kidney, they did not find any microscars. In terms of the microscars in the left ventricle, they found 64 scars from that section that they were looking for. Average diameter 211 micrometers, so tiny areas in the heart that are just fibrotic. And potentially then, these are potential triggers for arrhythmias. This is a very, very important information. And they went on to say in the paper, because again, they have to be careful. They've noticed the association with multiple boosters, but how can you know for certain that this was the cause? You need a lot more data. And so they went on to highlight that the cause for these cardiac microscars has not been clarified. The fact that these rare cardiac microscars continue to be found at autopsy within a short period of time, approximately 6 months, compels us to consider the involvement of current trends in the background. And so they're talking about the vaccination. They've not seen it before the pandemic. And suddenly you're finding it in patients who didn't have COVID as far as you knew. This is concerning. And so therefore it causes them to try and say, well, if I don't have a clear cause, how would I exclude the involvement of the jabs? And what we find these days is the scientific community is being disingenuous when they are telling people, well, there is no proof it is the jabs. Well, if you haven't got another explanation, that has to be the top of the list. But they're right. There is no proof, but we need to look for it. And you certainly don't discount it. Very, very important. And then again, they highlight here in their discussion, in all three patients, the ejection fraction of the heart, so it was contracting well, despite them having all these microscars. And as I said here, all three patients had histories of booster vaccinations, 6 or 7, 5 or 6, up to the last admission. And they highlighted as well a global survey showing that any type of COVID vaccine appears to instigate cardiac arrhythmias, and COVID-19 vaccines may lead to cardiac conduction abnormalities. They're being clear and to the point. That's what I call good science. They are not trying to gently mention it. They're just saying to the point, yeah, this is possibly the most likely reason. How can you discount it without further autopsies? And then you have here conclusions. Cardiac multiple microscars should be considered one of the differential findings for cardiac arrest. Further study is needed to identify and understand the characteristics of this disease state. Really, really important conclusion. And as I said, just to highlight what they said at the start, in effect, based on what they are seeing here, this is likely to be a new disease diagnosis. Not been seen before and found on autopsy, and it's a pretty good chance that as we continue to do autopsies, hopefully this will now trigger autopsies to be done, more and more cases will be found. And I look at the name here because this name should be important. It's Koizuma and Ono. Should they have this diagnosis named after them? Because what they have done here is they have broken through a barrier and forced the scientific and medical community to look at something that they should have been looking at for the past 4 years. There is no excuse for not doing autopsies. I don't care what anybody says. Novel virus, novel technology, unusual patterns of death, and no autopsies? That's almost negligent. What we have is a situation now where we have to get back to the science. And my hope is that people in across the world will start to ask the hard questions that need to be done. As I mentioned, make sure you go to the Substack if in case you can't see the full presentation. It will be there, as well as the links to the paper and a summary as to what I have spoken about. Please also remember to join me on the measles intensification among COVID. I'm going to try and make a connection here that is extremely important. And critically, if you are feeling unwell, have been struggling, make sure that you look at the potential of understanding what's happening with circulating spike protein testing and potentially detox if people are ongoing unwell. Final point. Now that you know this information, pass it on, friends and family. If you have any sudden deaths, raise this information to the pathologist or to the coroner. Say that you want a histological examination of the heart and you want to make sure that they don't have multiple microscars in their heart. This way, you can make sure that you are actually helping the science to move forward. It's not just about challenging the science, you will be helping science to move forward. Thank you very much for joining, and I look forward to sharing more information with you in the near future.